You're watching Cetome TV. Knowledge is power.
Okay, so go ahead. What do you want us to know?
So I thought I'd give a general overview. There's so many new treatments in female reproductive cancers.
Okay.
There's no way we could cover that in a single episode or multiple episodes. So we're going to have to break it down.
Okay.
So I focused on the most common types, and I focused on the causes.
Okay.
And the things that you can do in your life to avoid it as much as possible.
Most common types of ovarian cancer?
Yes.
Okay.
Yeah. So the symptoms, as I'm sure most people are aware, are persistent bloating, pelvic pain, postmenopausal bleeding,
Okay.
loss of appetite, and pelvic masses. At that time, either a scan is done or they look at what's called the CA-125,
Okay.
also known as a carbohydrate antigen. It's from a gene called the MUC16. And basically, this is a gene that's involved in a bunch of different cancerous pathways that's highly expressed on ovarian cancer cells.
But it's in males and females? It's just in this case
specifically in ovarian cancers. Okay. Yeah, that's what we look at.
All right.
So this gene is involved in cell-to-cell adhesion, a process called epithelial to mesenchymal transition, which is a cancer process where epithelial cells get converted into a more procancerous mesenchymal subtype. It's also involved in cell motility, so it helps these cancer cells move around and join together, and it's involved in chemoresistance. So first off, there's low grade. So today we're going to talk about low grade serous, mucinous, and then high grade serous.
Okay.
And high grade serous is really the one that needs the most conversation on, because it's the most common, and it's it can be a very deadly disease.
Okay. So we're going to look at 3 types of ovarian cancers.
And we're going to focus on high grade.
Okay.
So low grade typically arises in the ovaries, and this is important, and I'll discuss that why later. But it typically arises in the ovaries. It's basically believed to be a slow growing, and because it's slow growing, it has a poor response to chemotherapy, standard chemotherapy. And the reason is because standard chemotherapy affects rapidly reproducing cells. So a cell line that's slow growing is going to have less of a response. And I've seen reports as low as a 3 to 4% response to standard chemotherapy. Typical genes that are involved in this, which can be used for targeted therapies, are the KRAS, BRAF V600, which is common to melanoma, and MEK inhibitors are starting to be used in these too.
Okay.
So after that, they seem to be, most cases of low grade seem to be fairly responsive to aromatase inhibitors, and that's because they are an estrogen-based cancer.
Okay, and tell us a little bit about aromatase inhibitors.
Well, they're used for breast cancer.
Used for breast cancer. You tell me that like I should know that, but you're the cancer guy. I'm not the cancer guy. Okay.
Sorry.
Okay, thank you.
Then there's mucinous, and mucinous, as it may sound, is a mucus-based from the mucus-producing glands. It arises from typically benign or borderline precursors in the ovaries. Also comes from the ovaries.
Okay.
It's also not very responsive to chemotherapy. Typical mutations are P53 gene. There's an amplicon in this region of the genome called the chromosome 9p13. And then there's a lot of what we call copy number variation in mucinous. And copy number variation is where you have multiple copies of certain genes. Typically, these genes are going to be not tumor suppressor genes. They'll be, pro-cancerous genes and metabolic genes.
Oncogenes.
Oncogenes, yes, in general.
Okay. All right.
Yeah, so typical mutations to look for are signaling in the Wnt pathway.
Okay.
And then they're also looking at RAS and RAF inhibitors for these.
Okay. And this would be, in order to be able to tell if the Wnt pathway was involved or RAS or RAF, you need genetic
to do
testing.
genetic testing for
Mhm.
all ovarian cancers,
Right.
To determine exactly what type you
'Cause
have
there's too
more
much
specifically.
variance.
It's way too much variance.
Right.
Yes.
And the treatments differ.
Yeah, especially when you have a cancer that's not going to respond to chemotherapy, you need to rely on targeted therapies.
Mm-hmm. Mm-hmm.
So very, very important.
Mm.
And once again, if you have a disease that's not going to respond well to chemotherapy,
Right.
it's really important you
Mhm.
know all of your treatment options.
Like the low grade, you were saying earlier, the low grade serous, because it's so slow growing and
Exactly.
chemotherapy, it depends on
Mhm.
your cancer cells being rapidly reproducing in order to find them and
Mhm.
wipe them out. Chemotherapy wouldn't be so great for them.
Yes.
Yeah. Okay. All right. Oh,
So we're going to go into high-grade serous now.
okay. Sounds good. So
high-grade serous, which is the most common and probably the most deadliest.
Most common, huh?
Yeah.
Okay.
It occurs from what's called the serous epithelial layer.
Okay.
In the abdominal pelvic cavity.
So not the ovaries.
Not the ovaries.
Okay.
It was, for a long time, it was thought to have started in the ovaries and to stay in the ovaries and basically spread out from there.
Okay.
But now this layer, the serous epithelial layer, is very common in the ovaries. And that's why, they assume that it started there, and that's where it grows. So that's definitely where it grows.
Okay.
And what we know now is that it originates in the fallopian tubes.
Okay.
And this is very important.
Okay.
So the fallopian tubes have this area called the transition zone, where these stem cells that repopulate these areas exist. And so these cancers actually start there. And this has been a big problem because for many years, if someone had a low grade, a high grade but low stage form of serous, they would take out their ovaries and they'd leave in the fallopian tubes and everything else.
Yes.
Then the cancer would inevitably come back.
Right. Because it was growing in the fallopian tubes.
Exactly. So there was a study done by some BC cancer scientists, I believe. What they did was they looked at how, removing everything, having what's called a full radical hysterectomy or oophorectomy, yes. Having everything taken out really reduced the chances of this disease coming back if it had not metastasized already significantly. And even leaving in, little bits of tissue, almost guaranteed it would come back.
Wow.
It was significant rates.
Wow.
So, knowing the origin is very important.
Yes, right. Because if you were thinking it was the ovaries, you'd think, if I take those out, I'm going to be fine. And yet, not so much.
Exactly.
Right.
Yes.
Okay. So this is for the high-grade serous.
Yes, it's high-grade
which, as
from
you
now
say,
on.
is the most common and most deadly.
Yes.
So generally, the advice now is
take everything out. Don't even take a chance.
Thorough...
And we still see cases where doctors are not doing that. They don't have this information, and this information's been around for a long time. So make sure your doctor knows about it. We do. Up until I think last year, I saw a case where they didn't take it all out.
Wow.
So definitely.
Yeah.
So the causes. One of the main causes is, believe it or not, ovulation.
Oh. Being a woman.
Well, being a woman doesn't necessarily mean ovulation.
Okay.
So what happens is the number of ovulation cycles you have. If you have a lot of ovulation cycles, then you have a higher risk of high-grade serous. And this is because in ovulation, you have something called a cortical inclusion cyst.
Okay.
And that can be a cause of high-grade serous. So a protective effect, obviously, is to become pregnant, parity, and breastfeeding, because these stop the ovulation cycle. Now, this is where oral contraceptives are beneficial too, because they also stop the ovulation cycle. And so they have a protective effect.
I was wondering about that. Yeah.
So that's the main cause. There's a lot of other causes.
Okay, so you don't have to become pregnant, just so you know. You could take birth control and have some
definitely
certain types of
benefits.
birth control.
Yes, exactly.
Yeah. Okay.
Yes. Now, hormonal therapy during menopause is known to increase your risks.
Okay.
Now, I want to be specific there because we had an excellent question just recently. A woman was asking about the use of estrogen creams, and so on, hormone-based creams.
Okay.
Um,
As a potential cancer cause?
yeah, because a lot of women use these through menopause, use them on the genitals and different areas and so on. And so I did look up some studies, and actually, even if you have estrogen-positive breast cancer, these creams do not significantly affect it.
Oh.
Yeah, so you can still use these creams safely.
Well, that's good.
Now, one of the reasons too is the creams are typically signaling for estrogen receptor beta, whereas estrogen receptor alpha is what drives most estrogen-based cancers.
Okay, well, that's good. That's such helpful, that mechanism.
Yeah, understanding the mechanisms.
Yes. Okay. So the creams that women might use
for menopause,
seem to be okay because the ER beta is.
I think there was maybe a 1 or 2% increase, but it wasn't even really well established.
Right.
So
okay.
even if you have breast cancer, you can still use them.
But you did say something before that about hormonal therapy during menopause. Did you not say there's something about that can be okay?
Yes.
So how is that not this cream?
Because the cream doesn't enter the blood supply.
Okay. So the cream, because it's topical, it'll help with certain
Voltaren.
Symptoms. Okay, like pain management.
Yes, pain management.
Okay,
yes.
But the hormone replacement therapy enters the bloodstream, and so it has a very different effect.
Very different.
Okay, thank you for clarifying that. Yeah. Okay.
So another cause is polycystic ovarian syndrome.
Oh.
And lots of women do have that, so you want to be on the lookout for that.
Okay.
I think it doubles the risk of high-grade ovarian, endometriosis, and it can also endometriosis can also be a risk for various reproductive cancers. Another one is PTSD, or as you would refer to it as trauma. So there's a study where they looked at PTSD in soldiers, female soldiers, and they found that if they had 6 or more symptoms of PTSD, they had a 2-fold increase in their risk of ovarian cancer.
Wow.
Quite significant.
Yeah. Wow. So just that, and the mechanism there is.
I would assume it's hormonal. I would assume it's something to do with the stress hormones.
High levels of cortisol.
Cortisol, that's what I would assume. I don't have all that information.
Can also be coping strategies, as we were talking about earlier. Oftentimes. But yes, I can appreciate if you've experienced trauma or you're reliving trauma in the present day. That's going to keep those cortisol, those stress hormones high.
Yes. So another interesting study, and we're seeing this so much, and I think we should actually have a microbiota section for every show.
Okay.
Because it is the new, it's the new area of research.
Okay. Tell us more.
So when they looked at the microbiota of ovarian cancers, and they looked at different bacterial species, and they found that one thing was common with ovarian cancers, specifically, and they looked at women over 50 with ovarian cancer, high-grade serous once again.
Okay.
And they found that there's a higher prevalence of something called the O community, O-type bacteria, and a lower level of the type L, which are lactobacillus.
Okay.
And that was compared with women with ovarian cancer under 50.
Okay.
Now, when women also had a BRCA1 mutation, they also had a higher likelihood of having more of this O and less of the L.
Huh.
And then also a younger age of cancer was also associated with that, with a higher O and a lower L.
So you'll get it earlier if you have the higher O type bacteria.
Exactly, or if you have a BRCA1 mutation. What they found is that this high proportion of bacilli actually causes a lower pH in the vagina region, in the ovaries and so on. And so the lower pH, I believe it was a pH, quite low, definitely favored this protective bacteria and reduced the amount of the damaging bacteria. Yeah, of the O-type. Yeah, so obviously this goes in direct conflict with the alkaline diet philosophy.
Right. But just for those of you at home, do not rush out and try to massively modify your pH, because not only is that physically impossible, it will kill you. Right.
Yes, exactly. So alkaline diet.
Yeah. But if I did want to have more L and less O, which is what you're saying, right?
I think a probiotic might help that.
Okay.
I don't have a lot of experience with this, so I'm just learning myself. So
you're going to follow up with us, so we can make another video and give you a heads up there. But it couldn't hurt.
We don't have the data.
Probiotic.
We don't have the data for a probiotic yet.
Okay.
And obviously you want to look at what's in the probiotic, but we're starting to figure these things out.
And if you're thinking from a prevention perspective, then trying to make sure that you have that nice balance of healthy.
Well, interesting enough, the healthy microbiota comes from a vegetable Mediterranean-based diet.
There you go.
Yeah, that's one of the main things. You have more diversity, and that keeps everything in check. And then having a more limited diet, fast foods, lots of sugars and so on, can give you a negative, microbiota for cancers.
Right.
And all other diseases too.
Right.
So, once again, it's down to eating those foods, those important, Mediterranean-based foods.
Healthy veg. Right.
Yes.
Yes, because that just seems to have so much influence on so many of these other things. Yeah, and it is something you have total control over for the most part, depending on where you live.
You just have to teach yourself to like vegetables.
Yeah.
So another one is assisted reproductive technology, called ART, and that's a blanket field of reproductive technology.
Okay.
So in women that had ART, they were found to have a higher rate of ovarian cancer. But this ovarian cancer rate occurred about 15 to 19 years after they had the ART. So that was quite an interesting.
So we're not just talking about when you're talking assisted reproductive technology. So these are things like in vitro fertilization,
and the hormones involved in
hormones.
that.
And then it seems 15 to 20 years later, there is this
increased
side effect.
Yeah, and no, it wasn't just high-grade serous. It was actually a few different types of ovarian cancers too.
Okay.
So
there's other factors at play, obviously. Right. Wow.
So
do you have a number for us? What is the percentage?
I don't have the numbers.
Okay.
No.
All right.
Sorry.
Okay, but something to be mindful of.
Now this also, as you know, for women that haven't had babies or who are infertile, also have higher risks. And so ART was associated with about the same ovarian cancer rates. I do know that.
Oh, okay. All right. As people who did not have
babies.
Right. And therefore, as you were saying earlier, it seems to be directly related to how much you ovulate through your life.
Yes.
And this would affect that for sure.
That
so for those who already have had some sort of assistive reproductive technology, something like that, which, maybe it was last year or 10 years ago, and you've just heard Alex say that can increase your chances of developing this cancer.
Yeah, and it wasn't a huge increase.
Okay.
It wasn't like a substantial increase, but it was a noticeable. It was an increase.
It was measurable.
Measurable, yeah.
Okay. Where I was going with that is do not despair. Do not despair. There's so much you can do with diet, with exercise, with lifestyle changes, and there's genetic testing that you can have that help before cancer ever develops, to see if you do have some of those genes that might put you at a greater predisposition for developing cancer down the road, which can then help you to A, keep an eye on it, and B, make some significant changes to certain things that might exacerbate systems in your body. So whenever you hear Alex talk about increased risk of this, that, or the other thing, and it pertains to you, do keep in mind there's still lots you can do for prevention and just to keep an eye on things so that if cancer were to develop down the road as a result of something like this, you're on top of it super early and you have the best possible outcome.
Yes, definitely.
Yeah.
Definitely. So we're going to go to treatment now. We're going to be very brief about this, but general considerations. In some cases, high grade can develop from low grade.
Okay.
So it's always important to have your pathology redone over time. So if you have low grade ovarian and you're not responding so well to the treatments anymore, definitely get your pathology re-looked at, get a new sample and see if it's converted to high grade. It does happen.
Okay.
It's not the most common thing, but it does happen, and it's important consideration because the treatments will be very different.
But in this case, if somebody didn't want to go through the process of another biopsy, which could be understandable because it's not a pleasant process necessarily, we could at that point use the liquid biopsy.
Yeah, we could look at genes that are unique to high grade versus low grade.
So you could just have a blood test rather than having to go and have a whole nother tissue biopsy taken.
Yes, exactly. Yeah. So the main treatment typically for high grade is surgery, and once again, you want to have everything removed.
Okay.
So once again, this transition zone in the fallopian tubes is where these start.
Yeah. So if your oncologist is not recommending the removal of fallopian tubes and
everything, yes.
then you may want to either provide them with more current data or change doctors.
Exactly. So the standard chemotherapy is platinum-based drugs and taxanes, as they call them.
Okay.
Paclitaxel. For prognosis with standard chemotherapy, if you have overexpression of a gene called P53, which is the guardian of the genome, as they call it, it's involved, it's a tumor suppressor. It's one of the first tumor suppressors ever identified, and it's called the guardian of the genome. It's the most altered gene in all cancers.
So what they're saying is if it's working well, you have far less likelihood of developing cancer.
If you have expression of it, it's good.
Okay.
You're going to have a good response.
Okay.
If there is an expression of it, you have a high chance of recurrence with the standard platinum and taxane-based chemo.
Okay. High chance of recurrence.
Yeah. Now, on that note, I think it's about 97% of high-grade ovarians have mutations in P53.
Wow.
Yes.
That's huge. That's
and you don't see these in low grade. You do see P53 mutations in mucinous, but you don't see them in low grade, and that is one of the defining factors between the two. So
96%, that's quite prevalent.
Yes, huge. Yeah, definitely. There's also germline BRCA1 mutations. They're about 10%. BRCA2 mutations, germline, about 5 to 6%. And then somatic BRCA1 and 2 mutations are around 6, maybe 7%.
Okay, so for those at home, the somatic
versus a germline.
Right.
Yes.
So germline is what you're born with.
Yes, it's in every cell in the body.
And somatic is what's
only in the tumor.
Yeah.
So you're not passing those on. And then mutations in a set of genes that are associated with it, BRCA1 and 2, and they're called homologous recombination genes.
Okay.
And so if you have mutations in these genes, then you have what's called homologous recombination deficiency.
Okay.
And so if you have that, about 17%, maybe 20% of patients with high-grade ovarian have that.
Okay.
Then you're going to have an excellent response to platinum-based chemotherapy. But it also opens up the door for treatment with PARP inhibitors.
Okay.
So we've talked about PARP inhibitors before. They're a great new treatment for many different cancers, specifically towards those with mutations in genes involved in DNA mutation and repair. such as homologous recombination, such as the BRCA1 and 2.
Okay.
So if you have BRCA1 and 2 PARP inhibitor, typically, that goes for prostate cancer, breast cancer, but they were first discovered in ovarian cancers. So PARPs were first used in ovarian cancers, and that's where most of our data comes from.
Okay.
So right now we have 3 FDA-approved PARP inhibitors.
Okay.
They're approved for platinum-sensitive disease. That means, women that have responded to the platinum-based chemotherapy.
Okay.
And then we have one that is being tested.
Okay.
So the approved one's olaparib, which is one of the first PARP inhibitors ever. And that is being used. The most promising approach with olaparib right now is to combine it with Avastin, anti-angiogenesis. And that definitely improves progression-free survival and overall survival rates, specifically in women that have BRCA1 mutations or HRD mutations, so homologous recombination deficiency. Okay. Which once again is about 20% in these cancers. Okay. So there's another drug, a newer version called niraparib. It's a good drug. It reduces the progression of disease by about 30%. 40%. Okay. And up to 60% in women that have BRCA mutations, it's quite significant.
That is, yes.
It's being approved for newly diagnosed high-grade or endometrioid or primary peritoneal or fallopian tube. Okay. And, typically for women that have BRCA mutations specifically. There's another one, rucaparib. I haven't really looked at the data on that lately, but that's being used too. And then veliparib. Okay. Veliparib. That's the newer one. It's being tested. So that one seems to work fairly well. Okay. And so that has a progression-free survival in BRCA mutated patients of 34.7 months versus 22 months for patients not getting that with a BRCA mutation. And once again, these are women, that have fairly metastatic disease. So an extra year. Yeah, it's significant. Yes. For women with homologous recombination deficiency, veliparib gives you 31 months versus 20 months in this study. Okay. So again, close for another year. Yeah. Yeah. So what's so important to keep in mind there really is that there's so much new information and new treatments and then new ways of using existing treatments for certain genes and certain combinations that, if you're watching combinations, that's really where it's at. Yeah, because there's so many options then for different treatments, and an extra year might not sound like a lot. Maybe it does, maybe it doesn't. But a lot can happen in that year in terms of new information that allows your doctor to offer you new treatment options, or again, existing ones, but that are now shown to be beneficial for different purposes. And I think that's an excellent point that you just made, that I didn't specify, but the data I was just sharing was based on just the drug alone, single agent. Okay. Very few drugs work good as a single agent. They almost always combine with other drugs or chemo or different targeted therapies. So even if the drug is getting those kind of results alone, it's going to be a lot better with other combinations. Right. And if you know the genes that are driving your cancer, then you'll be able to have confidence that you're getting the right combinations. Right. And so that number you just gave should be significantly increased for a lot of people. Yes. Yeah. Okay. All right. So that's a lot of information. Okay, there's more. Okay. And so of course we can't, we have to stick with checkpoint inhibitors with just about every cancer we look at. Why? Checkpoint inhibitors are immunotherapy once again. Okay. PD-1 inhibitors. Thank you. So a recent study called the Keynote, and all all PD-1 inhibitors are basically, or most of them are based on the Keynote studies. Okay. So for advanced recurrent high-grade ovarian cancers, there's about a 9-10%. Now in these patients, 9-10% response rate. However, if they have a higher PD-1 level, over 50% PD-1 positivity, then they get a much better response. And this is PD-1 positivity specifically in their immune cells, not necessarily the tumor cells.
Okay.
So that's important.
Right. So that's an important distinction. Yes.
Yeah. And now what else is being used quite a bit, and I mostly see this in the States a lot, is a drug called, well, it's actually radiation therapy on microspheres called yttrium Y90.
Okay.
And basically what it is these microscopic glass spheres that are coated with radiation with yttrium 90. And what they do is they inject them into the liver. They just stay in the liver. And they seem to work quite well for ovarian cancer metastasis. So that's definitely an approach to consider. I don't see a lot of it in Canada, although yttrium Y90 is available in Canada. It just doesn't seem to be used as much as other countries, the States and so on.
But if you had evidence to show it was going to be beneficial for you,
we do.
You could make an argument.
For liver metastasis specifically, yes.
It's yeah.
And I'd like to finish up with a very exciting new drug, which is what we call the Trojan horse strategy.
Okay. Go ahead.
So this is basically what we call an antibody drug conjugate, and we're seeing a lot more of these.
Okay.
So there's a few different players in the market now.
Antibody drug conjugate.
Yes.
Okay.
Yes. So you have an antibody that seeks out a cell surface feature that's unique to the cancer cells and brings with it this chemotherapy drug. And so the antibody binds onto the cell and then it drops this chemotherapy payload. So that's why we call it the Trojan horse effect.
Okay.
So there's a new drug now for ovarian cancer called mirvetuximab.
Okay.
And so anything that says MAB on it, it refers to a monoclonal antibody.
Okay.
So this drug is basically, antibody conjugate. We call it targeted chemo because it actually targets cells rather than just dumping chemo into your blood. The antibody helps the chemo drug target to the actual tumor cells.
Wow.
Yeah, so it's quite fascinating. And so in this case, the drug has a couple different components. Okay. It's got something called a DM4, which is attached to a SPDB linker called soravantacine.
Okay.
So this is getting into the technical areas.
It is. I guess,
so basically what this means is that it has this linker that connects the drug and the antibody. In this particular case, this linker basically is unaffected in the bloodstream, but once it gets to the tumor, the linker itself also has a bystander effect. In other words, it causes some sort of, we don't know if it's an immune response or what, but it has what we call a bystander effect, and it kills other cancer cells, just the linker itself. So this is just the thing that attaches the antibody and the drug together. So now you have the antibody, which binds the outside of the cell, can also cause an immune response because something's attached to it.
Right.
Then you have, it's going to get its attention. Then you have the drug payload. And then now you have this linker too that also has some sort of cancer fighting property.
So triple targeted.
Triple targeted, yeah. And so it targets something called the folate receptor alpha, which is highly expressed. I think it's about 75-80% of ovarian cancer cells, high-grade ovarian cancer cells. Okay,
so it's definitely looking for something that's there and needs to be looked at, right?
Yes, exactly.
Wow, that's it. What's that called again? Folate?
Folate receptor alpha.
Okay. Wow. And this is the mirvetuximab.
Yeah, mirvetuximab.
Mirvetuximab.
Okay. And so as a single agent, now, as you know, just single agents don't have the best efficacy. They have to typically be combined with chemo or other drugs. But as a single agent, it had a response rate of 47%, which is fairly significant.
Yeah.
It's well tolerated. Side effects with these Trojan horse drugs are kind of unique. They're kind of rare and unique. They're not what we see in other drugs. So one of them is you get the sloughing off of cells in the cornea of your eyes, stem cells. These, is something to do with this receptor, but we see this in other drug conjugates too. And you see the sloughing off, and so patients get a blurry vision.
Oh.
And they get really concerned, and it causes something called, and I had to look this up because I've never heard of this, corneal microcysts, which is just a fancy term for debris. And so if you go into an eye specialist and you have these corneal microcysts, they're going to get very concerned because it often leads to blindness.
Okay.
But in this particular case, what it is it's just a side effect of the drug and is of these stem cells sloughing off into the cornea. Right. And as soon as you stop the drug, it goes away 100%. So it's 100% reversible. Okay. So it's a scary side effect, but it's not that bad.
Okay.
You can also get diarrhea from these drugs, and dryness in your eyes too. So you can use these droplets in your eyes and to take it away. But I mean, that's a lot better than
then losing your hair and all the nausea. And
I have heard stories of neuropathy too. I'm not sure about mirvetuximab, but I'm sure there's a little bit of nerve damage because it is a chemo drug.
Okay, but still.
But I think we're going to see a lot more of these. There's a great one for HER2 positive breast cancer called TDM1. We discussed that a few videos ago. And these drugs really are going to play a significant role in cancers. Targeted chemo.
These Trojan horse
drugs, antibody drug conjugates.
Because they're so targeted.
Yeah, exactly.
And, they're doing a whole bunch of different things.
Definitely.
Yeah.
Yes.
Oh wow. Okay, great.
So that's it.
That's it
all
for
I
now.
have for now.
All right. Okay, so we've covered three main types of ovarian cancers, and we've talked about some symptoms and things to do, treatments that will work well, things you can add to existing treatments. So that's very helpful. I think you've given the viewers at home a lot to work with.
And take home question. Get sequenced.
Get sequenced.
Always
right.
get sequenced.
That's, right. Yes. So that fun. Yes. And we can go into this another time. But when you're talking about sequenced, you mean having a tumor biopsy tested with a good quality genetic test.
Yeah, Foundation One or Caris or something like that. Yeah.
Or
MSK Impact.
A blood-based.
There's a bunch of great ones.
Yeah. Okay.
Thank you for watching CTOME TV. Subscribe below and stay informed.